morning, everyone. So my talk this morning is on complex knee injuries, which is a large but interesting topic. Just to go through a bit of background, so knee dislocations we don't see very often, but they are a significant injury to pick up. Often patients present with their knee already reduced, so the diagnosis is made based on the history. But some of the important aspects to detect include vascular injury, neurological injury, so 25% of patients may have a perineal nerve compromise, soft tissue assessment, so whether it's a high energy injury or an open, and lastly the diagnosis of the injury, so whether there's any fractures or ligament damage to the knee. Regarding the vascular assessment of a knee dislocation, we often see, well, they say that 5 to 15% of knee dislocations have some kind of popliteal artery or vascular compromise. So this can be assessed on physical examination, but also patients who present with some suspicion of vessel injury, such as reduced pulses or asymmetrical pulses, can be investigated further using an ankle brachial index, commonly used in which is basically the blood pressure at the level of the ankle, so the calf, over the artery on the same side, and should be above a ratio of 0.9. Also, so with a blood pressure cuff and a Doppler, yes, and then a Doppler ultrasound. CT angio or arterial ultrasound is then indicated in those with an ABI, ankle brachial index of less, and this is important to exclude more subtle injuries. In a patient with a more urgent setting, such as a cool pulseless limb, it's important to get urgent vascular involvement, and it may warrant immediate surgery or on-table angiography. Regarding CT angiography, this is a more current method of investigation which is taking over from conventional angiography. The advantages of it are that you can get access through the arm rather than through the groin, and allows for venous rather than arterial cannulation. It also has a much higher sensitivity and specificity than conventional angiograms. Surgical treatment is indicated, or emergency surgical treatment is indicated in fractures that are open, dislocations that are open, irreducible, or when there's evidence of. Knee dislocations, just moving on to the longer term management, they can be classified based on the direction of the dislocation or on the anatomy of what's injured. So direction is divided into anterior, posterior, medial, and whereas the anatomical classification, which is potentially more relevant, is divided into the different ligaments that are injured. So all the way from just the ACL plus one of the ACL and PCL. Grade 3 is ACL, PCL, one of the, and the more severe injury includes all 4. As I mentioned, this is a big topic, so what I'm going to go through is the areas of controversy, areas of decision making that arise when managing a patient after the immediate emergency setting, looking into and the timing, as well as the way in which we manage. So looking at operative versus non-operative treatment of knee dislocation. Basically, there's been a push towards more operative treatment since Dedman et al. presented a meta-analysis on retrospective reviews, retrospective case series of effectively looked at a range of different outcomes, including range of motion, the Lysholm score, which is a functional outcome score, and the return to pre-injury. Overall, patients who had operative management of their ligamentous injuries had improved range of motion and less of a chance of flexion contracture. They had a significant improvement in outcome scores, but the difference in return particularly the way, sorry, what the functional, sorry, the return. I think there was a mix, but regarding whether surgery is done arthroscopically or open, arthroscopic reconstruction is of the ability to assess other intra-articular pathology, potential decrease in infection rate with a small wound, and with prolonged surgery, the potential. Open surgery is, however, indicated in those that are open injuries, and also in fluid with arthroscopy. Also, recently there was further research. Standard et al. There's a range of papers that are into this, but this was a that overall showed difference in the percentage or the failed or outcomes from repair versus reconstruction. So in the group that had the repair of the posterolateral corner rather than allograft generally, there was a 37%. It is, however, important to, they did also identify a significant difference in the stability between the two groups on examination, but they had put those two groups together and overall the two groups had similar Lysholm scores. And difference in management. Regarding the reconstruction principles, so in a knee with multiple ligament there's three basic principles. So first of all, treatment with accurate tunnel placement, anatomical graft insertion, and strong graft. Lastly, extensive post-operative. So going into those different areas, there's different options as to whether initially, so at the early stage, or whether in the operative management. This is a brief summary of looked at the difference knee dislocation group. So overall, those that were managed acutely, so generally assessed less than 3 weeks. There was a higher functional outcome score seen in the acute group. There was, however, in the study by similar stories with the other papers with better functional outcome scores, but they all had reasonable follow-up as well. The issue with these trials is that, or with these outcome assessments, is that often the group of patients that are put into the delayed reconstruction injuries may have soft tissue injuries or other. Lastly, there are no prospective trials. So overall, stage surgery can be compared looking at, needs to be considered in significant instability or as I mentioned. And Finelli et al. Have been involved in classifying different types of ligamentous instability and have then gone on to use that to guidance on the way in which these should be treated in terms of staging. So in terms of ACL and PCL injury with a they've divided them overall into 3 main, as they go further down and using this, they've said that type A and B can be treated with, while type C injuries can often be starting with the medial and medial. Next part I was going to go into is about graft selection. Sorry. Oh, okay. Do you want me to go back? Yeah. You don't think it's useful? So B and C, they're saying it's more unstable. So varus laxity so I guess they're saying it's a grade 2, and but then they're saying that the lateral capsule is injured. Graft selections is more of a move towards using allograft over autograft for while autograft provides a biocompatible tissue and while allograft gives us the JBJ's paper in which this yeah, that's right. That's what. Going into the specific injuries, there's a lot of ways in which the ACL and PCL are reconstructed. Again, from the current review articles, they're recommending allograft reconstruction. And then there's other areas of controversy, including the way in which the PCL is reconstructed, single versus double bundle, but just get through. And lastly, just fracture dislocations overall have a poor result. And there's been a series of, so going through the reconstruction in 4 stages, starting with managing the soft tissues and reducing the fracture. Phase 2, over the the fracture or any avulsions, and splinting the knee at that. Third stage is the early reconstruction, mainly the collaterals, and lastly, Standard et al. Looked at a series of 50 patients following these 4 phases, outcomes from using this staged process. Post-operative management of knee dislocation. There's current research going into whether to manage is comparing the knee brace, which at the moment is showing the revision needs for those who are treated knee brace is much greater than and lastly, the overall rehabilitation includes a non-weight bearing patient for 3 weeks, locking an extension for 3 weeks, but then gradual increase. Complications of knee dislocations include vascular nerve. Also thought to be around a 40% risk of bathroom fibrosis. And another issue that's brought up in the so in conclusion, knee dislocations are a significant injury which require important and prompt emergency. Ligament management includes reconstruction, graft selection, and